So good afternoon, everybody. Thank you for joining us for this 45-minute session sponsored by Medtronic for EuroPCR 2025. I'm super honored to be the anchor person of this session to replace Professor Mao Chen that couldn't attend this year. And I'm even happier doing this with Dr. Song, Professor Song from Beijing. Together with the great discussants and panelists we have with me here, Professor Liu, Professor Zhou, Professor Feng, and Professor Chen and Professor Chiu, we're gonna cover a couple of topics which gonna show you the extent of the innovations and research from China. And of course, this session is only dedicated to TAVR and TAVR evolution. So without any delay, I'm going to ask Professor Young to start with the talk. Where is she? April, my friend. Yes. I was looking for you. So, April, you will be talking about long-term outcomes of left bundle branch area pacing compared with the right ventricular pacing in TAVI patients. I think the topics will be covering some unmet needs and problems related to TAVR, which is really very important and should not be neglected. April, we're listening, please.
So good afternoon. I'm giving this presentation on behalf of Professor Chen Mao and our EP team led by Professor Xu Yuanning. The title is Long-Term Outcomes of Left Bundle Branch Area Pacing Compared to Right Ventricular Pacing in TAVI Patients. So the reason why we're doing this research is despite new iterations of TAVI devices like Evolut and Sapien, we still face a significant portion of patients who need pacemakers after TAVI. So we're thinking and we're working closely with our EP colleagues how to improve the patients' centered outcomes if they need a pacemaker after TAVI. This is especially quite an issue in self-expanding valves. Okay. So on our EP side, it has been found that the traditional right ventricular pacing might have some negative effect on clinical outcomes after TAVI. Our EP physicians has, I wouldn't say recently, but over these years, they developed a new technique called left bundle branch area pacing, LBBAP, that has been proved to be feasible and safe in many patient populations. But the potential clinical benefits in the TAVI population remains to be demonstrated. So our team and our EP team, they kind of pioneered in implementing this LBBAP pacing treatment in all of our patients who needs a permanent pacemaker. So we are curious to know the outcome differences between a traditional right ventricular pacing and left bundle branch area pacing in patients who requires a pacemaker after TAVI. And by doing these kind of analysis, we hope that we can improve the long-term outcomes in the now younger and lower risk aortic stenosis patients. And this was a multi-center retrospective observational study including all consecutive patients undergoing TAVI for severe aortic stenosis who had the indication of a permanent pacemaker within 30 days after TAVI procedure in 3 centers in China. And there are, of course, some exclusion criteria. And the final enrolled patient were divided according to the pacing method they received. And it is by the decision of the local EP team whether they prefer a traditional right ventricular pacing or the left bundle branch pacing. And the final number in both groups was 117 versus 120. As a kind of background, during the time of this study, we do both methods, but more recently, the left bundle branch pacing is a more commonly used strategy, at least in our own center. And we followed up these patients to know about their outcomes, such as mortality, heart failure, rehospitalization, and NYHA classification. These are the results of our study. Was a relatively young patient population with an STS score of around 4.4%. And the TAVI procedure-related major complications were rare, both in the two groups. And at the last follow-up of the cohort, the paced QRS duration was significantly longer in right ventricular pacing as in previous studies comparing right ventricular pacing with LBB-AP, because the later one is more physiological. And at 5-year follow-up, there was no difference in the rate of all-cause mortality between the two groups, as well as the composite endpoint of all-cause death and heart failure hospitalization after multivariable analysis. But right ventricular pacing was associated with a significant higher risk of heart failure rehospitalization alone. And at our latest follow-up, the NYHA classification improved significantly in both groups compared with their baseline, but more patients in the right ventricular pacing group presented with NYHA class 3 to 4 compared to the LBB-AP group. And last but not least, patients in the LBB-AP group experienced a greater improvement of ejection fraction over the follow-up time. So from this study, this is the first study reporting long-term clinical results in patients undergoing LBB-AP following TAVI with comparison to the traditional right ventricular pacing. And it was associated with significant reduction in heart failure rehospitalization and more LVEF improvement compared to right ventricular pacing. So we encourage all the centers to consider do the LBB-AP to their patients after TAVI who needs a pacemaker. And of course, larger multi-center randomized data should be there in order to know whether LBB-AP is benefited in longer term follow-up. Thank you.
Thank you, April. Any comment or question to April from the panel and from the room, of course? Nobody. You have one.
Me?
Yeah.
Maybe. Yeah. Yeah, that's such a good study regarding the two kinds of pacing. So I just thinking about one question, probably for Dr. Song. Yeah, right now you're doing a lot of work. Right after the TAVI, you just continue put the pacing there, or or some follow-up and you can find out some very good result. So back to this study, probably right now, if you really want to do the pacemaker implantation, probably you have to find the EP guy, not us. Because standing here, maybe sitting here is a coronary guy, maybe some such a heart guy. So for your team, is you have to cooperate with the EP guy, right?
Yes.
So that's a question for me. Okay.
It's like it's more difficult than cooperating with a surgeon, April. You know that. So, how do you do it?
Yeah, can I ask a question?
Yes.
Yeah, Chris Wong from Hong Kong. It's a very interesting study. My question will be, for those that are repacing, that with heart failure, will you consider convert them to left bundle branch AP?
So you mean if the patient already had left ventricular heart failure?
Yeah, if they have RV pacing and you find about a certain number of them had heart failure.
Yes.
Yeah, will you consider to convert the RV pacing to the left bundle branch pacing? Technically, it's not that difficult.
Yes. Actually, from what I know, because I am not an EP physician, but from what I know, our EP team now tends to offer LVB pacing to all of the patients because they believe now the EP community believe that is a more physiological way of pacing.
Yeah.
So that would probably overcome the shortcomings of RV pacing that might cause chronic heart failure to patients.
Yeah, I did actually went to your hospital to learn the left bundle branch pacing a few years ago, and I'm so impressed by the number of LPB AP in your center. It's one of the largest centers in China. There are two centers like yours. So this is my idea that if those patients with RB pacing already, most of them are screwing leads. So unwind them and convert them to LBB AP might be something that you can do for future, that if you can see the heart failure improve with left bundle pacing. Because this is actually equivalent to a CRT today's.
Right.
And a lot of the center studies show that. So this is my question that will you actually conduct a further study from your subgroup converting those people with RV pacing to those left bundle pacing to see whether their heart failure will improve with time or not?
Okay, thank you for this suggestion. I will for sure transfer your message to our EP team, and now let Professor Xu know about the idea of conducting such an interesting analysis.
Yes, I think we do have such cases. When the QRS is quite wider, we need to transfer the patients to the CRT or like LB pacing. I think heart failure should be improved. Yeah, during the follow-up. Yeah, I have one question for you. Yeah, for some patients, it's very hard to put LBB pacing during the procedure. So what's the failure risk, during the study?
I am not quite sure of the failure rate because it's another physician who do this. But I think he is with his a very good hand for doing this. And I've heard that the LBB AP will only be done by Medtronic electrodes. And I think we have very good backup from their technical team. So at least from what I know, our hospital has a relatively very high rate of... So maybe you know the answer.
One final comment, please.
Yeah. When I was there, actually, their success rate is nearly 100%.
Yes.
And at that time, they used the Medtronic, the thin electrodes. But nowadays, there are other companies that are also producing some of those screw-in leads dedicated. But probably more important is the catheter. The introducer, that they have a special curve for the septal approaching for the leads. So when I went there, the success rate was more or less 100%. Very good.
You mean for the TAVR patients or only?
No, for all patients.
General
All patients.
Yeah. For some patients, if the valve is, deeply deployed. It's very hard, to get the right position. Yeah.
Doctor, I know Dr. Xu, he do every pace use the LAPP pace. So even not just for the TAVI.
So just a quick question. Did you look if they are more pacemaker? I mean, this effect you have been finding is more frequent with self-expandable or balloon expandable? It doesn't matter. It's just if you
The pacemaker rate?
Yeah, no. If the heart failure, when you pace a valve, a patient who has been implanted with a self-expandable is higher or lower than heart failure rate?
I don't think in this analysis they kind of subgroup analysis the different group with heart failure, whether the proportion of different devices. In fact,
so the idea is to eliminate any confounder factors that
yes.
could also play a role in that interpretation. Probably
yes, the
that,
prosthesis type.
Exactly.
Thank you.
I think it will be interesting to look at. Okay, April, thank you very much.
Thank you all.
So it's my honor to invite the next speaker, Professor Wang Yan, who will be covering another important topic in the management of some of the important complications we may face, especially in young patients. TAVR and coronary artery obstruction. Professor Wang.
Okay, thank you. It's my honor to present this risk assessment of a coronary artery obstruction following TAVR using FFR. I think it's around 1% the incidence of coronary occlusion, and it's a very higher in the valve TAVR case, and it's less in the balloon expandable valve, a little bit higher in self-expandable valve. But acute occlusion of the coronary artery is, we call it the earlier and late. The earlier that means less than 7 days after TAVR. Late means more than 7 days. The mechanism of this is a displacement of the native aortic valve leaflets in the thrombotic events or heavily calcified valve, as well as the fibrosis and the presented inflammation. The patients with the coronary obstruction is a very high in hospital mortality. The risk factor of anatomy factor is a low coronary height and smaller sinus and a narrowing STG and elongated leaflets and bulked calcified, and also the patients, female patients, and old age. I think this is a very interesting study. It's not a case-based study. It's an AI model, not based by the TAVI case. It's an AI model to predict the risk. Use this model also can predict the FFR with patients with relatively risk for coronary occlusion. I'm going to show you a case, very interesting case we did in our hospital. It's a 70-year-old male with a symptom dyspnea for 3 months, and the T result, you can say the patient has an indication for TAVR, and you can see the small annulus size and the LVOT like this. STG is 24-25, and the SOA is 30.9, and you can see the VTC is less than the valve to coronary less than 4 mm. A little bit high risk for coronary obstruction. You can see the anatomy like this. RCA height and the leaflets is a relatively long leaflets, you can see. For this strategy, we use Everroot Pro. We know the Everroot Pro is a good candidate for this one because of its has a alignment. We have the Everroot Pro. We don't have the new. The future maybe more. I just saw new is have a large cells in there. It's more protect for the coronary. Even use this technique, we can see the very good alignment. You can see the yellow arrow point here is a head like this, and we deployed this. Is it moving? I'm sorry. And this is very good alignment with. You can say you point to this to the 3 o'clock, and in this you can see the head mark is over there. When you cross it, head mark like this. So it's I think it's almost 95% of patients we can. 95% I can say very good alignment. It's very good for the future to treat the coronary artery. For this case, we use the balloon dilatation, 20 balloon, and use the Everett Pro 26. You can see a little bit our size, about 4, according to the annulus, 4%, and use a post-dilated 20 balloon. This is the final result. It's a good result after this one. But you can see left coronary is pattern, and the flow is very good. We try to use very easy to engage, use guiding to select the coronary, and use the wiring side. We use the FFR to measure this 0.96. That means coronary is good, so the patient is good. The next case I'm going to show is also a 70-year-old female. You can see the BMI is 21, 22, and the patient's severe aortic stenosis. We can say the STG is 27, and the SOA is 28, and the low of the left coronary heart is less than 12 millimeter. The leaflet is the length. For this case, you can see the anatomy like the right. I think it's a good case for if you use a balloon expander valve. We worry about the coronary obstruction. It's in the borderline, but it's okay. We selected our size about 10 to 15% of our size use this anatomy. Oh, I'm sorry, not sapien 3, it's a my valve. We select the 23 my valve with nominal and -1 cc. We worry about the coronary obstruction. So you can see that during operation, you can say we protect the left coronary with Godzilla inside and the balloon expand. This is the final result, is the right hand is the final result. So all the stent is too close to the coronary, but it's okay. Because the coronary flow is very normal and TIMI-3 flow, we just send the patients back. But in the third day in hospital, the patient got a symptom, and you see the ECG change and chopping eye increased, and new left bundle branch. We call the patients back, you can say. Even you do the coronary angiogram, you can still coronary pattern without any. I think the flow is good, is TIMI-3 flow, but the patient has MI after the TAVR. So we try to do the FFR. You can see the FFR is only 0.48. And we put a stent in the left main. After left main, we check the FFR again, 0.9. It's a very good result, and the patient is now very well. We have already do about 8 to 10 cases like this, use the FFR to evaluate is there any predict the future occlusion or future ischemia. Use FFR. I don't know is this work or not, but we try to start a clinical multi-center study for this, if anyone include. It's a lot of, I think, the length of the leaflets, height of the left coronary, and also use several the STG and as well as valve to the distance to the coronary. A lot of parameters. We combine this to say what kind of case. So far, we use the TE. Every case is finished with the TE if the residue is about 2 or 3 meters. All the cases we do the FFR. In our 8 or 10 cases or 2 cases, FFR is positive. So we put the stent. And the residue is okay. And so far the patient is okay. So we try to do this research, maybe can help us to. Yeah, thank you. And another, maybe all the patients we want to protect the coronary, the alignment. If you use the self-expandable stent, the alignment is the most important. So for the high risk of coronary, it better with a very good alignment. Thank you.
Thank you. So we have time, 4 minutes for discussion. Professor Chen, do you think that we should explore, do FFR in all TAVR patients? Or should we reserve it, as Professor Wang has been saying, to some particular cases?
Yeah, I think Professor Wang is a very pioneer clinical experience about how to predict the acute or delay coronary artery obstruction after TAVR. But I think, because just you mentioned the mechanism of coronary artery obstruction after TAVR, generally is a leaflet displacement and also calcium anatomy and also the the valve, the size. I think maybe if it's a high-risk case for the coronary artery obstruction, maybe I think so maybe imaging, because left man is the osteo of the left man, or right coronary artery osteo place. What about IRIS or OCT? I mean the imaging. Which one is better? Maybe for me, because it's a mechanism of the coronary artery obstruction after TAVR is quite different. So maybe imaging is a better way. I'm just wondering, what's your comment?
I think the FFR is the best view to evaluate the functional ischemia. IRIS is sometimes very difficult to see the osteo lesions there. Maybe there's a flap or something near to the left man, but it's difficult to use IRIS. I don't know what's the experience use OCT to see it outside the left coronary. Is there any good image there? I don't know, but I think so far FFR maybe is the best view to.
Yeah, Professor Wang, I mean, if I look at the anatomical factors that you're citing here, I think half of the patients should have straightforward FFR. Because, and then when you think about the delayed myocardial infarction, which could also be related to silent ischemic of the myocardium, I think it will be a pity not to, before discharge, before leaving the room, not to do this, because it's easy, no?
Yeah.
It's easy to do. And I think this is one of the reasons also, I mean, the latest implementation, for example, with Evolut FX is very important to use, because you have this large window. Just check it and let
Yeah.
And I think it's not only about advanced age, because for younger patients, I think it's even more important.
Yeah.
Because if you leave a silent ischemia of the myocardium, it could have a big damage. Don't you think so?
Yes.
Yeah.
Yes, I think so.
Yeah,
So let's
that's
do
like
it.
you said, I think Medtronic is taper design. You know, the risk of coronary obstruction is, I think, is quite low. Yeah. And I have one question for Professor Wang. Will you use drugs to induce the hyperemia condition during the FFR test?
Yes, of course.
Yeah.
Use the drug to
Will
do
you
the
use like a
FFR.
pullback technique?
Yeah.
Okay. Yeah, I think
And also-
you think maybe we can make it simple, like to measure the pressure only on the sinus and the other side of the sinus. If you put the the pressure wire into the sinus, if the pressure dropped, I think it might be ischemia. Yeah.
Okay.
Yeah.
Yeah.
I don't know if
Professor Joe has a question.
Yeah.
Yeah.
Dr. Wang is very experienced doctor.
Yes, thank you.
ABFFI is very, very important. Even all patients before the procedures, we assess the risk of the coronary obstruction. But some patients experienced the obstruction of the coronary. So before the procedures, if the patient has risk of the coronary obstruction according to the access, which kind of valve would you prefer? Balloon expandable valve or self-expandable valve?
Okay, it's a difficult question to answer you. Some patients, because balloon expandable valve is a short, height is around 21, 22. If the left coronary height is high enough, I think the balloon expandable is okay. But sometimes the borderline, the left height of the is a high risk to use a balloon expandable for this lower left, except the big Vasava. If it's a small Vasava, cannot acute occlusion. For this kind of cases, we try to select the self-expand. Sometimes you use the self-expand, you have neck there to got a very good alignment, a lot of this mechanism. And after we deploy it, we can decide we can post-dilate or not to protect the left main. And another question, another things I want to mention for the high-risk patients for coronary occlusion in our hospital, almost every cases we would like to use a TEE to evaluate the post-TAVR and decide to post-dilate or not, and then measure the length of the coronary to the valve and the flow there, and then decide to FFR or not.
So one final comment, and then we have to move to the next speaker. I mean, you've showed clearly that the idea or the belief that balloon expandable devices do not conduct to myocardial ischemia is not true. The MIVAL case is the demonstration that this could happen even with the balloon expandable devices. Yeah. Okay, thank you very much.
Thank you.
Yeah. Okay, we are going to move to the next speaker. It's Professor Guo Yuchao. He's going to report the TAILOR TAVR RCT update. Yeah.
Okay, thank you so much. My name is Yuchao Guo from the second affiliate hospital of Zhejiang University. Here I have great honor to present our clinical trial, TAILOR TAVR RCT trial. This is a RCT trial based on the bicuspid aortic stenosis, especially type 0 patient. We are using a downsizing strategy compared with standardizing strategy. Our PI was Professor Jian'an Wang, and I have no conflict of interest. In the TAVI era, we have a lot of challenges in bicuspid AS patient. We have larger annual dimension. We have more calcified leaflets. We have a lot of associated anatomies, so that it may cause a lot of problems. But first question is the reason why. Why did we choose type 0 bicuspid? Why? First of all, in China, the percentage of bicuspid is very high. It's among 50% in the overall TAVI population. Someone explains that to the younger age, maybe also some other reasons. Another is that among these bicuspid patients, first one is the three from the paper we published on urine intervention in 2022, I think. Among 109 bicuspid patients, we have 61% of type 0. So type 0 patient is very high in the Chinese bicuspid population. So we have this kind of patient population. So we have a lot of experience. So we want to study this patient group. Second is we have limited data available on type 0 bicuspid anatomy. We have a lot of papers published comparing bicuspid versus tricuspid, especially the morning presentation by John Forrest. We have the low-risk result, bicuspid result of 5 years. So we have similar result. Our center, we find that there is no difference between bicuspid and tricuspid regarding 2-3-year survival. And from the Young's paper published 5 years ago, they find the type 0 patient may have favorable outcome. That means lower mortality compared to type 1. This is in one of their figures, not the central illustration. So I just get that. So I haven't updated these slides. I haven't had time to stolen that slide from John Forrest. Sorry. Yeah. But we can see in the Evolute low-risk bicuspid trial, they only include like 93% of patients are type 0 bicuspid. The outcome, I think the 5-year mortality rate is 11%, and the pacemaker rate is 21%, because this study was done before the cusp overlap era. So the pacemaker is relatively high, but we find that the type 0 may have like less PVL compared to type 1. So in China, we have a lot of experience with bicuspid patients. So we are using different sizing technique to choose different valve size. So there have always been controversial about annular sizing and supra-annular sizing. CT-based supra-annular sizing remains controversial because it's very difficult to predict the size of supra-annular structure, especially after we do balloon pre-dilatation or we put in a valve, the leaflet movement is unpredictable. So here we present our technique. We call this Hangzhou solution. We use a balloon to assess supra-annular sizing. If we find there is a waste without contrast regurgitation, we will choose a smaller valve compared to annular sizing. So we can see this scenario A. If we use a smaller balloon, that means smaller than the annular size. So we see there is very clear with sign without contrast regurgitation. We will downsize the prosthesis. We will choose the one size smaller than the annular sizing result. And another 3 scenarios, that means either there is no waist sign or there is any contrast regurgitation, we will use annular sizing. So it's a very convenient and immediate way to see the leaflet movement and choose prosthesis size during procedure. So here's our study hypothesis. We believe this downsizing strategy may offer better clinical outcomes compared with standard sizing strategies. We may have higher device success rate. We may have fewer new pacemaker implantation. We may have lower rate of new onset RBBB. So this is our RCT trial. We have initiated study 3 years ago. This is a multi-center, single-blinded, prospective superiority design randomized clinical trial. This will include 206 patients from 15 centers in China. We will randomize them one-on-one to supra-annular sizing strategy versus annular sizing. The primary outcome is VAC3-defined device success and free of pacemaker and also free of new onset BBB. So there's one shining point of the study. We will do like pre-TAVR CT and post-TAVR CT of all the patients so we can have that data. And we will follow this patient annually until up to 5 years. We try to maybe make it longer. Yeah, this is our key inclusion and exclusion criteria. We will include patient type 0 patient, of course, on CT, and severe aortic stenosis with age larger than 65 years old, with patient with age larger than 60 but under 65 must have very high risk. And the exclusion criteria include severe mitral stenosis and also severe aortic dilation larger than 50 millimeter. This is a little bit different from the US or EU guidelines, but in China, we have discussed multiple times with our surgeons. This in 50 is a acceptable threshold. And also horizontal aorta larger than 70 degrees. And we will measure the risk of coronary occlusion and annular rupture risk, and we will exclude this patient, and also prior pacemaker implantation. So as I mentioned, we have a composite endpoint with special emphasis on the conduction disturbance. So if all of the 3 components meets, we can claim that this patient have our composite endpoint. So this is our SOP, standard operation protocol. So for patients with annulus dimension between 20 and 23, we will use a 20 millimeter balloon to predilate. For patients with 23 to 26, we will use 23 balloon. If the waist sign is seen and less than mild contrast regurgitation are seen, we will choose a smaller size. So it's very simple. So this study has already included 147 patients from 15 centers in China. I don't have enough time to thank all the investigators and contributors here, but thank you so much for supporting us. So to sum up, bicuspid is very complex and very challenging in this TAVR era. This TAILOR sizing strategy may offer better outcome for this kind of patient. We are waiting for the largest RCT trials on type 0 patients. Thank you so much.
Thank you, Dr. Guo. We hope that we can have wonderful outcomes with Medtronic on type 0. Yeah, and the Chinese strategy. Yeah, the downsize strategy. Yeah. Okay. So any questions from the panel? And
yeah, I have a question.
Yeah.
Why the 20 balloon? Why not 21, 22? I mean, why do you think that this is more accurate than any other balloon? This is one. And the other one is, I mean, I know that Professor Wong has a huge experience in this. And so he has his eyes of expert. But if I want to use this in my center, how can I get away from subjective evaluation of what you call the wrist sign? You know what I mean? Maybe the wrist sign for me with my bad eyes is not the same as was yours. So this is, you know what I mean? Anything we are doing, I mean, making a measurement based on CT is very scientific, you know? We draw the line and we all do the same. But when you look at the screen and say, oh, I think there's a wrist here, there's not a wrist here, it's more subjective.
Yes, I totally agree. For the first question, why do we choose 20 millimeter balloon for the 20 to 23 patient? First, if we choose like 21, 22, the balloon size is a little bit larger than the annulus size. It may increase the annulus rupture risk. So that is why we use like 20 millimeter balloon for this kind of anatomy. So to increase the annular rupture risk. For the second question, that is this objective or subjective? To be honest, it's not that subjective, but it is very convenient, and it's during procedure we can see that. And if you do like predilation very often, you can see most of the operators they will have this kind of common sense on this with the sign. Will there be any with the sign or not? So I think it's very convenient, but we are trying to update this to more like objective way. Yeah, thank you so much.
Yeah.
I have. Which kind of the valve do you choose? Why?
Yeah, we use. We only have like Evolute Pro at that time, so we use Evolute Pro. Yeah, but we hope if we have like FX Plus, it may improve the coronary access, may even improve the patient outcome, I think.
It's a very good
because the stenosis is zero. How do you conduct cost overlap?
Yeah, that's a very good question. Because all our patients are like type 0 patients. They only have like no right fee, they have 2 commercial, so it's not possible to conduct like commercial alignment in type 0 patient. But we can put 1 commercial post between the right and left coronary. So we can use similar like projection view as the cusp overlap view, like RAO caudal, we can achieve similar result. We have a small study ongoing that we hope we can see that on the post-TAVR RCT.
Okay, thank you. Now time is limited. We only have 1 question.
No more question.
No more question, but I still have 1 question. Yeah, just 1 question. Okay. Yeah. If we do many times pre-dilation and post-dilation, the stroke rate, is going to be increased, right? According to the study before. And also according to the study from your center, bicuspid valve, have even higher stroke rates. Yeah. Will you use a neuroprotection device during the procedure?
Yeah, that's a tricky question. Yeah, because we have limited access to cerebral protection device in China, so we didn't mandate each center to use cerebral protection device, and the price of this device is very high in China. So we hope we can use cerebral protection device for each patient. We have the brain injury paper. We have find that there's more stroke points compared to tricuspid patient. Yeah. I highly recommend that, but based on the economic situation, sometimes it's limited.
Yeah, but it's going to influence, the stroke rates from Medtronic in China. Yeah. Okay.
So you have to invest in the protection device.
Yeah.
The package.
Okay. Yeah. Okay. Thank you. I think we need to conclude this session. Many thanks to Medtronic, not only for the session they sponsored, but also for good products. I think the Chinese data is even perfect, right? The mortality is less than 0.5% maybe, and pacemaker, yeah, pacemaker rate is less than 5%, 1.8. Oh, it's comparable to balloon expandable valve. So, yeah, because we always downsize, Thomas. Yeah. Okay. Yeah. Yeah. Okay. I think I want to thank we have wonderful 3 talks about RB pacing and also the FFR assessment for coronary risk and also the TAILOR TAVR RCT. But we are looking forward for the outcomes. Yeah. And many thanks for Thomas and all the panel here, and also for all the audience. Thank you, PCR. Yeah.
Thank you.